Welcome again, my colleagues. This is the sorry. This is the second GIT MRI online hot 5 session. Candidate candidate 2 or 3 is ready.
Yes, sir.
Yes, could you request control? Welcome. Request control, please. This is
Okay, sir.
15-year-old female patient presented with abdominal distension for 1 month. Go on, doctor.
Okay, sir. Okay, I'm presented with the MRI of a 15-year-old patient presented with
Raise
abdominal
your
distension
voice,
for 1
please.
month.
Doctor,
Um,
raise your voice. Raise your voice.
Sir, I'm presented with the MRI of the abdomen of a 12-year-old patient presented with the abdominal distension for 1 month. And the first noticeable or significant abnormality that I can see on this image is that there is significant enhancement of the peritoneum noted. Yes, significant smooth enhancement of the peritoneum noted, and I can see that there are few areas of nodular enhancement also. Now, as I scroll upwards, I can see that this is continuous with the pelvic region as well. So, in the provided image, I can see that this is basically post-contrast. There is enhancement of the peritoneum. The first differential that is coming to my mind is and also there is some omental caking noted. So the first differential that comes to my mind is peritoneal tuberculosis. Um,
Okay.
Second, I would like to see it on other sequences to see other visceral involvement, and if the it proved to be peritoneal tuberculosis, I would like to see the chest X-ray of the patient for confirmation of my findings or any recurrent abnormality, concurrent abnormality. Okay, this is T2 axial sections of the same patient. In this which in this I can see that there is again same findings are redemonstrated, but I can see that the nodules are also noted. I can keep the differential of ovarian lesion also with the metastasis to the peritoneum, and a mental caking is also seen. So both the features are seen. These features are seen in
Recording
mental.
in progress. That's my teacher.
I'm present
Hello.
recording in pop.
Mute yourself, my colleagues. Mute, please. Hello, doctor.
Hello.
Yeah.
Sorry, I didn't know I was muted. So my first differential is TB, peritoneal
Yes.
tuberculosis. Second is mental. Second is ovarian malignancy. As I can see, some nodules and some septi also. So these both, and some mental caking. So these features are seen in both. I would like to send the patient for histopathological correlation for aspiration of the fluid and further management accordingly.
Thank you, doctor, so much. It was a case of tuberculous peritonitis. As you see here, very nice description, really. I so impressed. Look here, my colleagues. Uh, please, my colleagues, mute yourselves. Everybody other than the candidate in the seat, mute yourselves. See my colleagues here. This is the peritoneum market enhancement here. The peritoneum, and this is a large amount of fluid. Plus irregular large nodular enhancement. Look here, my colleagues. This is the peritoneal fat, markedly abnormal signal, edematous. All of this. Look here, my colleagues. Even the TP extended to both ovaries. You can't separate or differentiate the ovaries from the inflammatory masses. Somebody may consider this is a large cystadenoma or cystadenocarcinoma. No. Why? This is impossible. If this cyst or cystic mass lesion, it must exert mass effect where, or it should not be like this. This is like, see, this is the peritoneal itself. Okay, my colleague?
Yes, sir.
Is it clear? Thank you, doctor, so much. What is your next step?
So next step would be X-ray chest for confirmation or to see any recurrent pulmonary tuberculosis, and if it proved to be TB, then we will isolate the patient as it is contagious and will follow the patient accordingly.
Thank you, doctor, so much. See, my colleagues, it is difficult to be a large cystadenoma or cystadenocarcinoma, despite you showed both in your differential list, but this is most
Vishal,
likely ascites. This is ascites due to this in peritonitis. Look here, my colleague.
इसका बोल चरोस हो रहा है.
My colleagues, please.
उसको उठा के इधर ले आना. मैंने
Please, to save your time, mute yourself. Okay, my colleague, this is too huge to be just a single cyst. This is a peritoneum filled of fluid due to tuberculous inflammatory reaction. Okay, and the second, look here, especially here. See, except these areas, rest of the, especially here in the anterior, the wall is uniform. Okay, my colleague. Anyway, we showed both possibility, but tuberculosis is the first possibility. Thank you so much,
Okay,
doctor.
sir.
Next
Thank you, sir.
candidate. Thank you. Hello. Hello.
Candidate 1, please proceed.
Assalamu alaikum, sir. I'm candidate 4.
Yes, welcome. 1 second.
Hello.
1 second, doctor. I think we finished this case before. 1 second, doctor. Okay. Doctor, this is 45-year-old female patient with chronic diarrhea and recurrent abdominal pain. Request the mouse, please.
Sir, I requested.
Okay, and raise your voice, please. Go on.
Sir, I requested.
Yes.
Okay. These are the T2 weighted MRI images in a 45 years old female patient
Yes.
who presented with pain. Sir, just give me a second, please. Okay, the uterus is enlarged and has a hypointense, well-defined lesion in its posterior wall, which is indenting its lumen, likely fibroid. There is a cystic area seen posterior to the uterus, and this cystic area is seen. It is very well defined, has a line, and is seen in relation to posterior to the uterus. Uterus has some Nibothian cyst as well, and there are prominent parametrial vessels. There is I'm trying to locate its location in relation to rectum, but I'm not able to identify. So, sir, can I go to the coronal sagittal images, please? T2 weighted, because I'm thinking in line of some cystic region, which is posterior to uterus and anterior, might be anterior to rectum. So the findings are re-demonstrated. I think this is positive contrast This is the positive contrast is given in the rectum. So there are multiple Nibothian cysts, and I'm not able to identify anything significant within it. Sir, can I see the axial fat set images to see, because there are multiple cystic areas are seen, and I'm thinking that it could be cervicitis or any multiple Nibothian cysts which has led to this adhesion type of appearance. Mm, I would also like to take the history of any previous intervention. So these are the T1, T2 fat set sequences of the same patient in which there is there are altered signals seen adjacent to the uterus, and this.
Doctor, did you remember the history? I'm listening for you for at least 3 to 4 minutes. Did you remember the history?
No, so there was some pain,
No.
non-specific pain.
No, I mentioned the full history.
Sorry.
Again, let's start again. Read the history. 45-year-old female patient with chronic diarrhea and recurrent abdominal pain. Look here, doctor. What is this?
This is diffusion weighted.
Okay,
These are the
what
DW
happened?
sequences.
What happened? In patient
On the
with
DW
diarrhea.
sequences,
In patient with
so
diarrhea.
there is
Hmm.
so there are multiple areas of the small bowel which are showing enhancement along the wall with
This is not
diarrhea type of
enhancement.
appearance. One of
Doctor,
it is in the central.
doctor, this is not enhancement. This is diffusion.
It is showing diffusion restrictions. Multiple bowel loops are showing diffusion restriction.
Okay.
There are in the yes, there are skip lesions seen in the distal terminal ileal region at the level of ileocecal junction and in some of the rest of the bowel loops as well.
Which
So I would
sequence
like
do
to
you
take
want? Ask only for one sequence.
T1 fat set contrast enhanced. So in this the part which we're showing diffusion restrictions are showing enhancement. I would like to see for any luminal constriction which is not seen. There are prominent vasa recta seen adjacent to this enhancing loop, suggestive of Coombs sign, and this part is not showing any. This is also showing adjacent prominent vasa recta. Next, I would like to see the skip lesions are there, enhancement is there. I would like to see any stenose segment. There is also pericecal wall enhancement. I'm trying to look for any fistulous communication between the gut loops, which is there is might be this area, but yes, this one, no, this is not.
Give
I
me
think there
final
is
diagnosis. Final diagnosis.
no skipping. Final diagnosis is acute on chronic Crohn's disease with no active fistula, but with the positive ileal inflammation and positive vasa recta, suggestive of acute inflammation. Next, I will advise correlation with the previous cases to see whether these are same segments were involved, and also MDT referral to suggest the disease activity status and discuss the further management.
Thank you so much, doctor. Doctor, see, this case is a big lesson for all of us. If the examiner informed you about the history, he means something important. Why? Because in the exam, this is a very large case. Abdomen and pelvis MRI, at least in our practice, normal practice, At least we need 15 to 20 minutes to report. Okay? But the examiner should guide you because you only have 5 minutes. See, the examiner told you the patient has diarrhea and he give you MRI and the patient is still adult, 45. So first concentrate on the bowel, especially small bowel, either Crohn's or ulcerative colitis. Okay, my colleagues, very important the history, very critical. Thank you so much, doctor. It was a case of active Crohn's disease. Thank you so much.
Okay, sir. Thank you.
Next candidate. Next candidate.
Assalamu alaikum.
Alaikum
Candidate
assalam.
5.
Doctor, this is,
Hello.
yes, this is adult patient with chronic recurrent abdominal pain and weight loss. Request control, please.
Sir, I'm candidate 3.
Hello.
Hello, sir. I was candidate 3. I think the candidate.
Okay. After
Okay, candidate 3 can go on.
after candidate 5, doctor. Okay.
As
Candidate 5, request control, please.
okay.
Okay, sir. I have
Please, my
requested.
colleagues, to save our time, anything related to session arrangement and regulation, text Dr. Nagam or text in the group. Doctor, this is an adult 45-year-old patient with chronic recurrent abdominal pain and weight loss. Go on.
Okay, so this is the MRI axial section, T2 weighted image. I'm just going to scroll through the images once. Sir, I have taken the request, so can I scroll? Okay. So I'm just going to scroll through the images, and I can see that the bowel loops appear to be not dilated; they are normal caliber. I'm looking at the wall of the bowel loops. I can see that the wall is normal. Okay, so since the patient is having chronic diarrhea and weight loss, my concern, okay, so I can see that there is I'm trying to look at the ileocecal junction. Okay, so at the ileocecal junction, I can appreciate that there is some, I'm concerned for some thickening in the area here. Sir, can you see my arrow?
Yes. What else?
And also as I scroll down, there is within the bowel loop, I can appreciate some hyperintensity.
Don't worry about it. What else, doctor? Doctor,
Okay.
stop here. 1 second. 1 sec. What is this?
Yes.
What happened here?
Okay, so yeah, I
will help you.
Okay, this is
Let me help you. Look here. What happened? What
okay,
is-
so there is some, I think, teethering in the mesentery.
Okay, what else? Not tethering. See, I will help you. What happened here?
Okay, so that the ileum, the ileocecal junction is basically there is thickening along the ileum. along with some mesenteric mixed hypointensity mass. And
Okay, but look, see, this is sickening, okay? Okay?
Yes, sir.
And this is sickening.
Yes, sir.
This is many discontinuous sickening. What is the name of this? This is sickening. What is the name of this discontinuous sickening or inflammation?
This I will think in line of possibility of eyelid thickening tuberculosis or
No.
Crohn's disease.
No tuberculosis at all. Discontinuous, non-continuous inflammatory process of the ileum. What does it mean for you?
Okay, this
Okay. See, this is bowel loop attenuated, and there are connection from bowel to bowel to
okay,
bowel.
so Crohn's disease, I will think of in terms of Crohn's
Yes,
disease.
excellent. Okay, what is the complications that you see here? Connections, tracks between the bowels, multiple tracks. See,
Okay.
these tracks surrounded by
Okay, this is
fibrosis.
fistulous.
Yes. Again, what is the name of it?
So
Yes,
these are fistulous communications.
so give me diagnosis.
So it's a complicated chronic Crohn's disease. So
Complicated by
so
multiple.
next
See, doctor.
multiple fistula formation. Yes.
Why this is not tethering? See. Why is this not
Yes, sir.
not the tethering and the carcinoid? Look at T2 or at stair. Where is the mass? See, where is the mass? Where is the mass here?
Yeah.
Compare with
Yes, sir.
post-contrast. This is fibrosis. Tracks, fistulous tracks surrounded by fibrosis. Okay. Second, look at the wall itself. Multiple escape lesion. And compare all the sequence with each other. See? There are
Yes, sir.
tracks. See, this is
Yes,
track.
sir.
Track. And what else?
Yes, sir.
What else? This is track.
Yes, sir.
Thickening. Okay. So yes,
sir.
it may be looks like tethering of desmoplastic reaction of the carcinoid, but this is not the issue. The bowel here, small bowel here are highly inflamed. Okay, doctor. Okay.
Yes, sir.
Look here.
Yes, sir. Thank you, sir.
See. Look.
Yes, sir.
Look.
Yes, I can see the track now.
Tracks, multiple fistula. This is penetrating Crohn's. This is looks like chronic. Many tracks, many fibrosis. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Welcome.
Hello, Assalamualaikum.
Don't worry, my colleagues. I'm trying to concentrate on the examinations that we are not familiar to it or not familiar to us to cover everything. Alaikum assalam, doctor. This is 25-year-old female male patient with abdominal pain. Request control, please.
Sir, I have requested remote control.
Yes, welcome, doctor. Go on.
Okay, these are MR enterography images.
Doctor, are you sure
The
this is MRE or MRI?
Sir, I think this is MRI T2 weighted images because the bowel is not too much distended to the degree of MR enterography.
Finally, this is MRE or MRI?
This is MRI coronal T2 weighted image of the abdomen and pelvis of 25-year-old patient. I think history was abdominal pain. I couldn't recall.
Okay, but you were right in the beginning. This is MR enterography. You are right. See, the bowel is distended by fluid. So this patient has been prepared. This is intended preparation. Look at the colon. See, look at even the small bowel. No, this is prepared. Okay, so this is MRE or MR enterography. Trust in your first answer, my colleagues, as I mentioned many times. Go on, doctor.
Okay, these are MR enterography of 25-year-old patient. I can see that there are multiple filling defects right over here in the lumen of the large bowel, the transverse colon, and also I think also involving the lumen of the small bowel.
What else?
Now I'm looking. Sir, I'm looking at the pattern of the small and the large bowel. Yeah, I think in the pelvis. Sir, I need to see the terminal ileum.
Stop here. What happened here? No, leave them out.
Okay, sir, yeah. Right over here, there is a diffuse area of thickening involving the terminal ileum right over here, and also it is extending into the ileocecal region. I am looking at the yeah, there is also, I think there is also infiltration of the these abnormal cigarette intensity areas. Some are also involving the mesentery adjacent to the terminal ileum. So in the rest of the small bowel, there is no significant dilatation of the small bowel proximal to this. So I can put differentials in this case. It could be a case of Crohn's disease, or could be a case of tuberculosis, abdominal tuberculosis. Other differentials include typhlitis.
Okay, what history should you ask about?
So there could be specific travel.
No.
History of.
No. What else?
There could be yersinia due to typhlitis, yersinia, Crohn's disease. So you could see this.
Okay, what question do you want to ask to prove or exclude typhlitis?
Sir, in the typhlitis, there is usually fat, and also the patient's fat, creeping fat. It is in
history.
Sorry.
History.
Sir, history of neutropenia. If there is any history of neutropenia.
No. What else?
Sir, any immunocompromised or any history of chemotherapy?
No. So, what sequence do you want?
So, diffusion weighted sequence to see further its signals.
What happened here?
Yeah, it shows restricted diffusion. Yeah. Okay, this region of the abnormal thickening in the terminal ileum, it shows a restricted diffusion on the diffusion weighted images. So further supporting some inflammatory etiology of the bowel in the region of the terminal ileum.
So what's your final diagnosis?
Sir, it could be due to inflammatory etiology, could be Crohn's disease, or
Yes.
could be due to Yersinia,
How
or due
could
to
you
tuberculosis.
how could you rule out a complication? Which sequence do you want?
Sir, contrast enhanced also.
Okay, but there are no contrast. Thank you, doctor, so much. See my colleagues. This is the contrast, sorry. Hmm. Do you detect?
Okay, there is significant amount of enhancement in the terminal ileum and also in the surrounding mesentery.
Yes. What else?
So I think this is there is also sir, can I couldn't scroll it.
Yes. What type
Yes.
of Crohn's? Active or chronic or non-active?
Sir, active. This is active because it is showing enhancement.
And diffusion risk.
Yeah, and also diffusion restriction.
So finally, it is an active Crohn's disease. See here, please, my colleague. Thank you, doctor, so much. When you are starting,
Thank you.
keeping in mind the history and try to start from the point of importance. Try to start from the pathology. Why? The examiner didn't mind, not care about anything normal, especially at the beginning. Okay, so have a look and keep in mind this patient has recurrent abdominal pain or whatever. So you will, and this is MRE. Sure, you will concentrate on the bowel, especially small bowel. So when you find this one, start from here. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Assalamu alaikum.
Muslim request control.
Okay.
70-year-old female patient presented with jaundice.
Okay.
يلا.
Yes, I'm
No
trying
problem.
to scroll.
Take your time.
These are the axial images of the MRI abdomen, T1 weighted images of a 70-year-old female who presented with jaundice and weight loss. I can see that there is intrahepatic biliary dilatation. There appears to, sorry, this is jumping.
Leave the mouse. Leave. I will help you.
Okay.
What
Sorry.
happened here? Yeah.
Yeah, there is a dilatation of the intrahepatic bile ducts both in the right and
Yeah.
left lobe of the liver, and there appears to be a heterogeneous area that is at the confluence of the bile ducts.
Okay.
It is showing a hyperintense signal on the T2 weighted image, and the gallbladder is distended and shows a mild pericholecystic fluid. I am trying to see the extrahepatic part of common bile duct. Yes, the extrahepatic common bile duct is also dilated,
Mm-hmm.
and no evidence of filling defect within the common bile duct.
Mm-hmm.
So there could be a stricture in the distal part of the common bile duct.
Okay. Excellent.
Can I see the distal part? No filling defect in the distal part. So, considering the age of the patient as well as intrahepatic biliary dilatation, there could be a stricture in the distal bile duct, which could be um, cholangiocarcinoma. I would like to further. I would refer the case to the hepatobiliary MDT and advise the ERCP as well as biopsy.
What's your expectation or differential for this distal stenosis?
It could be a stricture or
the patient has no any history of his instrumentation.
okay.
So
Mass at the distal CBD.
okay, what else?
Okay. Another possibility, if the patient is having history of fever, it could be cholangitis.
Okay, but look here, this part of the head of pancreas, it is very subtle, by the way, very subtle.
Yes, yes, yes. Okay.
So we may include,
Periampullary mass.
Periampullary, okay, and pancreatic head tumors, okay? So this is
Yes. Okay.
marked
Yes.
extra and intrahepatic biliary dilatation. Look here, my colleague. Marked, okay? With
Yes.
no stones inside it, no filling defect. But
Understand in gallbladder. Yes. Yes.
yeah, but number one C, even the pancreatic duct is slightly dilated. And see here,
Yes.
here is the site of stenosis or stricture. So at least tell the examiner the
Yeah.
possible differential. Okay? Pancreatic
Okay.
head
Okay.
tumors, Bullavatar, anyway. Okay? Thank you so much, doctor.
Okay. Thank you.
Next candidate, doctor, request control.
Sir, I requested.
Go on. This is 85-year-old female patient presented with jaundice. Go on.
Yes, sir. So I'm provided with T2 fat sat images, X-ray
Raise your
images of
voice,
MR
please.
abdomen, and with
Raise your voice.
I'm provided with T2 weighted MR images, fat sat images of the abdomen, in which I can appreciate markedly dilated intrahepatic biliary channels
Yes.
and gross dilatation of the central intrahepatic biliary channels near the porta hepatis. These are converging centrally into at the level of porta hepatis. Gallbladder is distended and shows a hypointense filling defect in it, representing a calculus. I'm looking for some pathology at porta hepatis, which is causing obstruction. First, I will scroll the images. In the peripancreatic region, there is mild inflammatory fat stranding. Pancreatic duct outline is slightly lobulated, and these dilated intrahepatic biliary channels showing abrupt cutoff at the level of porta hepatis. I would like to see the
Yes.
post-contrast images of the patient and MRCP to look for the enhancing mass in the region to rule out the central intrahepatic periductal infiltrating cholangiocarcinoma.
That
On
is what?
MRCP images, multiple maximum intensity projection images are provided, and these are showing moderate to gross dilatation of intrahepatic biliary channels, and along with distended CBD, cholelithiasis, no definite
Okay.
pancreatic head mass,
What's your opinion
and
of this gallbladder?
sir, yes, the gallbladder, lower part of the gallbladder also shows thickening, and this thickening is extending to involve the pericholecystic region, the hepatic lobe. So the possible differential in this case can be the gallbladder carcinoma of the lower half or the neck region, which is infiltrating the secondarily
Excellent.
the porta hepatis,
Excellent.
common hepatic duct.
Yes,
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 and then
excellent.
causing retrograde dilatation.
What's your next
So
step?
yes,
What
so I
will
will
happen?
advise. I will refer the patient to the gastroenterologist for ERCP guided assessment and biopsy and for
How
histopathological
come?
confirmation.
One second, one second. How come this patient can go undergo ARCP? How come?
Sir,
What is ill? What is the
ERCP,
first step?
yes. So first of all, we will drain the patient. I will request the intervention radiologist to put a percutaneous transhepatic drain for
Okay.
immediate relief of the obstructive jaundice, and then ERCP guided stent can also be placed
Yes.
via this common hepatic duct to the distal CBD, which will further drain it.
Yes.
And then ultrasound guided or CT guided biopsy can also be performed. Even the interventional radiologist also can perform the percutaneous transhepatic biopsy.
Okay, thank you so much, doctor. Look here, my colleague, marked intrahepatic biliary dilatation. Please follow it. We are now in the superior part, upper part of the liver. Go down, down, down. Here at the porta hepatis, and no any, this is the common bile. No any common bile duct dilatation. So the problem at the porta hepatis. Okay, it is very difficult, by the way, to detect, really, frankly speaking, without contrast, without other planes, to diagnose anything in the gallbladder in this situation. However, look here, there are some thickening. We expect or we make many possibilities like flat skin tumor because the point of transition point is at porta hepatis here. Okay, but here, as I think, there are some soft tissue. From where this soft tissue came? Maybe from here, gallbladder. See, almost connected with it. And the gallbladder shows non-uniform, like here, non-uniform neural thickening. So this is carcinoma of the gallbladder infiltrating porta hepatis, and the convolution of both or the biliary system. Thank you so much. The first step is BTC and the drainage. This is first. Okay. Then other. Thank you, doctor, so much. Next candidate.
Hello, sir.
Hello. I think it is request control. I think this is the same case.
Okay.
1 second. Different case. Request control, doctor, please.
Okay, requested. Okay, so I've been presented with
75-year-old male patient with jaundice.
Crohn.
1 second. 1 second. Hello, go on.
Okay. So I've been presented with the two weighted images of the upper abdomen of a patient who is 75 years old and presented with upper abdominal pain. First of all, I'm going through the images. So here I can see that there is dilatation of the intrahepatic biliary channels with dilatation of the CBD, and I'm trying to look its distal extent. So it is dilated till within the pancreatic head, and I'm suspecting there is slight thickening at the opening at ampulla. So I am just trying to look for the presence of any filling defect. So I can see there is a defect within the lumen of the biliary
Okay.
common biliary duct. So there are also small signal voids are seen within the lumen of the gallbladder. So I'm suspecting cholelithiasis with retrograde dilatation of the biliary channels.
What else?
So I will. Okay. So I'm looking at the pancreas.
What else?
Okay. So the liver, I'm looking at the liver. There is the dilated intrabiliary channels shows somewhat irregular walls. So it may be due to bleeding appearances, maybe due to ascending cholangitis. So I'm looking at the bowel loops to see the presence of any
inflammatory bowel disease in this patient.
What else, doctor?
So in the okay. I'm suspecting dilated as CBD is quite significantly
Okay,
dilated.
stop here.
So this
One
may
second.
be
One second. Leave them.
pardon.
What happened here? Do you
Okay.
remember the age of patient?
You're 75 years of patient.
Okay, look at this pancreas.
So
Is this acceptable for this age?
um
What happened?
there is uh
What happened here? Look at the pancreas. Why is the
and
pancreas surrounded by fluid?
okay, so this is causing this obstruction may cause pancreatitis.
Yes. But what
Yeah.
about the size? What about the signal?
The pancreas appears swollen and there is loss of normal serotonin of the pancreas. So
Yes. So what
this
is your final
could be due
diagnosis?
to pancreatitis.
Final diagnosis?
So this is cholelocolitis pancreatitis in this case.
Yes, gallbladder stone complicated by pancreatitis. Okay, leave the mouse.
Okay.
What will you do
Thank you.
next?
So I will convey the finding to the referring physician and ERCP suggested in this case to remove the stones and relieve the obstruction in this case.
Why obstruction of the CPD leads to pancreatitis? What is the mechanism?
Because the status in the pancreatic enzymes within the pancreas will cause inflammation and autodigestion of the pancreatic ducts and pancreas.
What happened to the pancreatic enzymes to get activated?
Just stasis, I guess.
No, see the stone here obstructed the CBD. Okay.
Okay.
Do you think there are some reflux of the piles into the pancreatic duct? And so,
Okay, yeah.
so there are activation of the pancreatic enzymes. Okay.
Okay, thank
This
you.
is, by the way, difficult case. My advice for all of you, look at the patient age. When you see the patient age is older patient, please in CT abdomen or in MRI abdomen, the pancreas, tell yourself, the pancreas will trick me, will confuse me. Why? Because really this is looks like the normal size, but of adult. And there are minimal pre-pancreatic fluid. Not a big deal, but if this is adult patient, okay, my colleagues, but in older age, it must be atrophic. Must, يعني, more than 50% of this pancreas size should not be seen in this age. So this is edematous interstitial pancreatitis surrounded by minimal pre-pancreatic fluid. It was a case of distal CBD stone complicated by pancreatitis. Thank you so much. By the way, my colleague, frankly speaking, this is acceptable till now to make any mistakes. Why? Still have a time. And second point, most of my sessions, I concentrate on non-familiar systems, non-familiar cases, atypical cases. Okay? So don't be sad. Repetition will add, because knowledge is cumulative. Don't worry.